Welcome back to Clinical Challenges in the Management of Complex Patients with Type 2 Diabetes Mellitus, presented by Albert Einstein College of Medicine, Yeshiva University at Diabetes Series Live. My name is Tracy Mitchell, and you are tuned into the live session titled The Role of the Kidney in Glucose Homeostasis, Understanding SGLT-2 Inhibition with Dr. Mark Stoller. For those just joining us, I would like to remind you that today's session is a live interactive program that allows us to take questions in real time throughout this presentation. I encourage you to send us your questions anytime by typing them in the box located at the lower left-hand side of your screen. I'd now like to introduce our presenter, Dr. Mark Stoller, Associate Professor of Clinical Medicine and General Internal Medicine at the Northwestern University Feinberg School of Medicine. Welcome, Dr. Stoller.
Thanks so much, Tracy, and welcome everybody. Thank you for participating today. And I'd like to really discuss an exciting new area in diabetes, but it's exciting not just in a therapeutics point of view, because in diabetes we've gotten a little bit too carried away with medicines. Much in the way we treat hypertension, we just view medicines as interchangeable. We've now got a new approach. The ADA has come up with a new approach to treating diabetes, where it's individualized treatment. It's no longer rigid standard care. And so what we're going to discuss today is this new class of medications, the SGLT-2 inhibitors, and introduce it to our audience, and how they fit in with these new guidelines. So let's get on with the program. So these are our learning objectives today, and hopefully by the end of this hour, you'll understand the role of the kidney, which plays an important role in diabetes and in health. Normal human physiology, the kidney is actually very important in glucose metabolism. We're going to focus on the importance of glucose control. We've kind of backed off a little bit on that and focused more on cardiovascular complications. Tight glycemic control still is important for the majority of our diabetic patients. We're going to look at this new class of medications, first discussing the physiology. What does SGLT2 do? Most people aren't familiar with it. And then lastly, we're going to look at these drugs, these SGLT2 inhibitors, and how they can be used using case-based learning to discuss how do they fit in with individual patients. So with that, to help me understand where to kind of frame the information today and to help Tracy with the Q&A, let's just ask a few polling questions. So you've got to wake up just to enter your answers to these few questions. How comfortable are you in describing the role of the kidney in the pathophysiology of diabetes? Very comfortable, somewhat comfortable, slightly comfortable, or not at all comfortable? Please select one.
You know, the answers are coming in. You know, very comfortable sitting at 13% right now. Somewhat comfortable, going back and forth between 29, 31%. I think people are changing their minds as they're putting this in. Slightly comfortable, 37%. Not comfortable at all, 27%. I mean, that's a big number to look at. So, you know, it's moving back and forth, but I think that's where we stand.
Okay, so we'll spend a little extra time on that. We are filming this in Chicago. You can vote more than once. Second, how knowledgeable are you in regarding the physiology of SGLT2, that pathway in glucose metabolism? Again, so choose one answer that describes your knowledgeability of this pathway.
Again, they're rolling in. Let's see. People are kind of changing their minds. The numbers are changing on this one quite a bit. Very knowledgeable, that's sticking at around 13%. Somewhat knowledgeable is coming in at 26%. Slightly knowledgeable, 39, 40%, going back and forth. Not at all knowledgeable, 26%.
Okay, so we'll spend some time, and these are new medications, and there's some barriers to even getting them for your patients because they are so new, so we'll spend some time on that. And then lastly, how confident are you in understanding the role of these specific medications in day-to-day management of diabetes? So not so much the pathophysiology as how do you use them in a given patient? Give us your confidence level. Ooh.
This one is kind of shooting around too, Dr. Stoller. Let's see, very confident is down at about 7%. Somewhat confident, 20%, slightly confident, 46%, not at all confident, 28%. So we're sticking around that mark.
And I'd expect that. I think one of the issues with diabetes is getting a comfort level with a medication, especially with all of our safety concerns these days. So we'll hopefully make you more comfortable and confident by the end of the program. So let me get into the content. This is the new paradigm for treating type 2 diabetes, individualized care. And so every other chronic disease we treat in internal medicine is a patient-centered approach, except for diabetes. We've always used this algorithmic-based approach. And that really divorced management of the disease from the pathophysiology of diabetes. So we just said, it didn't matter what you used to lower glucose, you just had to lower the glucose. Well, that's still very important to control blood sugar, but we're now beginning to realize that different mechanisms work in different patients. And more importantly, our targets for glycemic control are different in different patients. More intense younger, less intense older. And so what that brings is sort of a need to understand how our medications work and what pathways they work through. And when we add medications, are we getting synergy? Are we getting overlap? And do they make sense together? The ACE guidelines have always stressed individualized care, but the guidelines from this group of clinical endocrinologists has talked about adding combination medications rather than single medications alone. There are no combinations that include an SGLT-2 inhibitor, but it focuses on being more aggressive in controlling patients earlier on. So this is sort of a framework for how ADA has said, who do you want to have different goals in? So if you look at the left-hand side of the slide, you're going to have more stringent targets for an A1C. That's going to be the younger patient, the patient newly diagnosed, who's motivated, able to participate actively in their diabetes management, doesn't have a lot of comorbidity, doesn't have cardiovascular disease. That's a patient you may choose an A1C goal of 6 if you can get there safely and easily. On the other hand, we know that in the patient with long-established diabetes, with other morbidities, with underlying cardiovascular disease, the elderly, you're going to have much less stringent targets. An A1C of 7 is fine, and actually in the patient over 80, the new target is 8 or below. And so we're going to tailor our management decisions based on the individual patient. So I want you to think of the left-hand side as disease management. That's where you're trying to change the trajectory of the diabetic patient's course of illness. The right-hand side is going to be more glucose management and safe glucose management, meaning without hypoglycemia. And I think the interesting thing about this new class of medications is it allows us to meet both objectives in terms of lack of hypoglycemia and safety, but able to get more difficult patients to their appropriate target. So we've always known that there are long-term benefits of tight control, but we've always looked at it from the perspective of what's happening during the study. So patients who are tightly controlled during a study have fewer complications. But there's been 2 trials, the EDIC trial looking at type 1s and the UK-PDS looking at type 2s, who followed patients for 8 to 10 years after the intervention. And in both groups, the patients reverted back to where the tight group had the same glycemic control as the conventional group. But after 8 to 10 years, even though their control was the same at that point, both groups had persistent microvascular benefit. And actually in UK-PDS, some macrovascular benefit as well. And we call that the legacy effect, metabolic memory. The problem is that these long-standing insights have been diluted by some of our more recent trials. For example, the ACCORD trial, the VADT trial, the ADVANCE trial did not demonstrate significant reduction of microvascular complications or macrovascular complications with intense control. And so we've tended to back off on being aggressive, especially earlier in disease, saying there is no benefit. Well, much as the first 2 trials showed that there is indeed benefit from early tight control, there's such a thing as bad memory too. And so this is one of the reasons why prior studies did not show benefit from intensive management. If you look at, for example, the VA group, they had an entry A1C of 9, which is really quite poor. And so those patients had a generation of bad legacy. Their metabolism and complications were set in a negative way. And you would have to keep those patients under tight control for 8 to 10 years before you saw a beneficial legacy. And so I think the take home for you is don't give up on the concept of getting patients to target. And more importantly, in the earlier, younger patient, there probably is a favorable legacy. Differential targets. There's a rationale for this, and we tend not to look at the kidney. Microvascular complications we've always assumed are due to long-standing disease.